Second speaker is Professor Jasmine Luzum from Clinical Pharmacy. She will tell us about preventing adverse drug reactions with MGI.
Okay, thank you very much for the invitation to talk today about how we're using MGI data to prevent adverse drug reactions. We've talked a lot about how hard medication is to work with. We have a College of Pharmacy 2 blocks away. We love medication, so come see us about medication data. So here's my outline. I'll really briefly cover what are adverse drug reactions, or ADRs. I'll briefly cover different ADRs that we're studying with MGI, and then I'll show you our preliminary results for a particular ADR called drug-induced long-duration syndrome, or DILQTS. So first I'll start with what are adverse drug reactions. So lots of different terminology is used to describe adverse drug reactions. You may have also heard adverse drug events or adverse drug effects, or ADEs. Side effects is probably the most common terminology used by our patients. They're also called drug-induced toxicity. But for simplicity's sake, let's just say adverse drug reactions are bad things that happen for medication. We use medications, we want to do good in our patients, but unfortunately, medication can also cause harm. So ADRs are a major source of morbidity, mortality, and costs in the United States. So it's estimated that adverse drug reactions are the fourth leading cause of death in the United States. Or fourth leading cause of death. So the FDA published this statistic before the COVID pandemic, so this may have shifted to the fifth leading cause of death, but really, look, this shouldn't even be in the top 10. This shouldn't be in the top 20. More people died estimated from adverse drug reactions than AIDS and automobile accidents. So approximately 700,000 patients per year are treated in emergency departments for adverse drug reactions. Thankfully, a lot of the times these adverse drug reactions aren't so severe that the patients can be sent home after they're seen in the emergency department. But a lot of times the adverse drug reaction is so severe that the patient needs to be admitted to the hospital. So approximately 120,000 patients per year are hospitalized for adverse drug reactions. And it's estimated that adverse drug reactions cost the United States healthcare system up to $5.6 billion per year. So adverse drug reactions are a huge, huge problem. How can we prevent adverse drug reactions? Well, I'm preaching to the choir here because genetics is one of the ways that we can prevent adverse drug reactions. So our best and most successful example in our field of pharmacogenetics is probably for the HIV drug abacavir. So abacavir causes a life-threatening hypersensitivity reaction, and it was found that a single genetic test for an HLA variant can prevent that life-threatening adverse drug reaction to abacavir by 100%. So rarely do we have anything in medicine that works 100% of the time. And this was published in New England Journal several years ago. So we are using MGI to discover new ways. How can we use genetics to prevent different kinds of adverse drug reactions? So here's some of the adverse drug reactions we are studying with MGI. One is with statins. So statins are cholesterol-lowering medications. These are the most prescribed drugs in our country. They're highly effective for the treatment and prevention of atherosclerotic cardiovascular disease. Unfortunately, the number one reason why patients won't take statins, even though they're very effective, is a common side effect of muscle pain. So we're using MGI to discover and validate genetic variants that increase patients' risk for having muscle pain with statins. We're also studying DOAC. So DOAC stands for direct oral anticoagulant. So this is a new class of blood thinner drugs. They're kind of replacing an older blood thinner called warfarin. A major adverse effect or too much effectiveness from these drugs is actually bleeding. So some patients can bleed to death when they take these drugs. So we're using MGI to discover genetic variants to hopefully identify patients who are highly sensitive to these drugs and are at risk for having serious bleeding on these drugs. We're also using MGI to study anthracyclines. So anthracyclines are a class of chemotherapy. They're a very highly effective class of chemotherapy used to treat several different kinds of cancer. Unfortunately, some patients have heart damage from anthracyclines. So we don't want to damage the patient's heart in the process while we're treating them for its cancer. So we're also using MGI to study that adverse drug reaction. And finally, there's 41 medications on the market in the US that are classified as very high risk for causing abnormal heart rhythms. So this is actually the example I'm going to talk a little bit more about where we got some preliminary result. So this adverse drug reaction is called drug-induced long QT syndrome. So this work is led by an outstanding PharmD PhD student in my lab, Anna Lopez de Dina. So she really led this work. I just have the privilege of being invited to present it to you today. So what is drug-induced long QT syndrome? So we have these 41 medications that are known to be high risk for prolonging the QT interval on an EKG. So you see the point? No. So the solid black line in this figure is what a normal heart rhythm looks like. The vertical dashed lines are measuring the QT interval. The red line shows when that QT interval can be prolonged. So how do these 41 medications prolong this QT interval? So that normal heart rhythm is controlled by the flow of ions in and out of channels in our heart. So picture here below is just the genes for some of those ion channels. And one of these channels in particular, the hERG channel, because of its structure, it has this pocket that some drugs can get inside this hERG channel and disrupt the flow of potassium ions in this channel. So it's causing a prolongation of that QT interval. So why is prolonging this QT interval a problem? Well, the longer that it's prolonged, the higher risk for a very terrible arrhythmia called torsade. So I don't think you need to be a cardiologist to be able to see that this heart rhythm pattern does not look like that heart rhythm pattern. The best case scenario with torsades is maybe the patient will just faint or have syncope and it'll spontaneously recover. But unfortunately, torsades actually has a very high mortality rate. So what are these 41 medications, you might be wondering, that can cause this fatal adverse drug reaction? Well, I will tell you, probably every single person in this room has taken one of these medications in your lifetime. So here they are classified by their drug class. So the first class are antiarrhythmic, which is kind of surprising. These are medications that are supposed to normalize your heart rhythm, right? These are actually the medications where you have the highest risk of torsade. Really commonly used antibiotics. So probably everybody in this room, you've taken a Z-Pak or azithromycin or Cipro in your lifetime. Really commonly used antidepressants, citalopram and escitalopram or Lexapro. And another really commonly used one on the bottom is ondansetron. That's generic for Zofran. It's used a lot to treat nausea. So very, very commonly used drugs. It's estimated that drug-induced long QT syndrome occurs with approximately 2 to 3% of all prescriptions written in the United States. So why are we using MGI to study this adverse drug reaction? One of the reasons is a candidate gene we're focusing on. So about 0.1 to 2.5% of patients, depending on ancestry, carry a genetic variant that slows conduction of one of the ion channels in the heart. So this variant is BCNU1, D85N, or RS1805128. So here we have our 41 medications. They're getting into that hERG channel, slowing down potassium flow through the hERG channel. But then there's also about 1% of patients who have this genetic variant that is also slowing potassium current through those channels. So we think, and others have thought, the combination of one of those 41 medications plus this genetic variant would significantly increase your risk for drug-induced long QT syndrome. So we're not the first to study this. There have been several previous clinical studies testing this association, but most of them were very small. So with less than 200 cases of drug-induced long QT syndrome. So we're really fortunate to have this large resource and to study this in a larger cohort, because we can't make any clinical recommendations. This is not very definitive until we test this in a large cohort. So our hypothesis was that patients in MGI carrying the DCNA1, D85N genetic variant have significantly higher risk for drug-induced long QT syndrome than non-carriers. So here's the inclusion-exclusion criteria. So Anna searched MGI, and this was freeze 4 because, like I said, there's a lag. It took her over a year to collect the clinical data for this study. So in freeze 4, she identified adults who had genotype data at MGI. They had a QT interval measured with an EKG during a prescription for one of those 41 high-risk medications. So she took her that medication data for 8,000 people for all 41 medications. And she identified 8,029 patients. She excluded patients who have congenital long QT syndrome. So there are some rare genetic variants that can cause QT prolongation in the absence of any external factor. She also excluded patients who have left bundle branch flopped and use a pacemaker because that interferes with how you can measure QT interval. So that left a final sample size of 6,759 patients. The analysis was limited to just the patients who self-reported as white race. None of the non-white MGI patients actually carried this variant, and that makes sense for the minor allele frequency of this variant. It is more common in European ancestry and pretty rare in non-European ancestry. So a primary outcome was presence or absence of exaggerated QT prolongation. So we did look at this as a binary outcome. So why did we do it this way? So here's the QT interval again. It's argued actually what is the normal QT interval. It has to be corrected for heart rate. So let's just say approximately the normal is 420 milliseconds. It's also based on sex. So most of us, like probably all of us, when we took one of those medications on that list, we probably all had a small increase in our QT interval. And usually that's not harmful. It's when you have really large increases, this exaggerated QT prolongation, when you take one of those medications, that really increases your risk for it turning into torsades. So for every 10 millisecond increase in QT interval, your risk for torsades exponentially increases. So because we did a binary outcome, we used logistic regression. Model 1 was unadjusted, unmatched in the full cohort. I'll show you on the next slide that in the patients that did and did not have prolonged QT, there was a lot of differences in the clinical risk factors. So model 2 used one-to-one propensity matching, and that sample size was 1,852. And then to not sacrifice so much power in that propensity matching, we did model 3, where we used the propensity score as a covariate in the full. So here's the baseline clinical characteristics of the patients who had normal and prolonged QT in MGI. So of those 6,700 patients, Anna found 926, or almost 14%, have this very exaggerated QT prolongation while they're taking one of those medications. So the patients who had prolonged QT, they were significantly older. There was actually fewer men. They had significantly more electrolyte disturbances, way more use of loop diuretics, digoxin, beta blockers, which you would think would be protective against abnormal heart rhythm, and significantly more comorbidities. So when she was able to propensity match all of 926 of those cases to 926 controls, and actually kind of normalize the clinical differences between those two groups. So this is the first look at the frequency of this variant in the normal and prolonged group. And so we did see significantly more carriers of this variant in the prolonged QT group of about 3.5%, and 1.6% carriers in the normal group. So here's our main results: the association of the KCNE1 D85N variant with drug-induced long QT syndrome. So on the x-axis is the odds ratio, and this is on a log scale. And so you can see across the board, no matter how we adjusted this model, this variant was significantly associated with increased risk of drug-induced long QT syndrome, with an odds ratio of about 2, almost threefold higher risk in that model too, where actually the clinical risk factors between those two groups were pretty similar. So we conclude that KCNE1 D85N is a significant risk factor for drug-induced long QT syndrome in a large real-world clinical cohort. So what could this mean? What is the potential impact? So we think that genetic screening for KCNE1 D85N before patients are prescribed one of these 41 high-risk medications could prevent unnecessary morbidity and mortality. So what could that look like? So here's our current treatment paradigm where we're prescribing these 41 medications. Some patients in this cohort, 14% had exaggerated QT interval, and some patients can die on Torsades. So we think we should be doing a more personalized treatment paradigm where in those 1% of patients who are carrying this variant, we can modify that therapy in some way. So is there an equally effective alternative medication that's not on that high-risk list? Can we substitute an alternative? If there is not an equally effective alternative, maybe we at least more closely monitor those patients. Like we order an EKG after their first dose to make sure that's not going to turn into Torsades later. So future direction. So QT interval is a surrogate outcome for a more serious clinical outcome of Torsades. So Anna right now is doing the laborious chart review and e-burst review to collect clinical outcomes to see if this effect translates to clinical outcomes. And also this is not a very common variant, but Dan Roden and his group at Vanderbilt developed a polygenic risk score of 61 common variants. And Anna actually replicated the effects of that polygenic risk score too. So stay tuned for that manuscript within the next few months. So big thanks to my lab, especially Anna Lopez-Medina, who led this work, our collaborators, our funding, and the outstanding resources at the University of Michigan that made this research possible. Thank you all for your attention.
Questions or questions?
Thank you. That's fascinating. I can see that being very clinically useful. Is your student coworker considering other channelopathies, whether they're cardiac or neurologic, that may have that variant implicated and could benefit from this piece of knowledge?
We haven't looked at others. I mean, we're interested in the drug. We're in the pharmacy school. We're interested in the drug induced.
I know.
So no, we haven't looked at it.
Yeah, I'm just guessing that some of the other channelopathy-related conditions may have their own sensitivities to drugs. Anyhow, that's a future direction.
Okay.
Okay, great. Because of the time, let's thank the speaker and we'll move on to the